Welcome to the newborn assessment. First, we want to gather our supplies, clean gloves, and a pediatric stethoscope. We want to make sure our hands are washed and that the vital signs were documented in the computer. Next, we want to gain the permission from the infant's parents for this exam. Once we have done that, we want to identify the infant through the parents. We do not want to fuss with the infant right now, checking the ID bands. We will check that later as we go along. So now we're just going to check the sleep-wake cycle. We're going to observe, are they in a deep sleep? Are they in a light sleep? Are they crying? Next, we're going to look at the muscle tone. We're going to see, are they moderately flexed? And that's what we would want. Or are they super rigid or super flaccid? So now we're going to open, and I want to note that this infant is under a warmer. Otherwise, the infant would lose a lot of heat. So now we're going to move on to the head, and we're going to do a skin assessment throughout. So we're going to look at the head. We're going to note if there's any bruising or cuts that may have occurred. We're also going to note the sutures, whether they are split, approximate, or overlapping. So we're going to identify the bones and the sutures. Here we have the frontal bone and the frontal suture. And on the sides we have the parietal bones, and then you have the coronal suture, and then you have the sagittal suture. And then on the back of the head you have the occipital bone with lambdoidal sutures. And you would also want to note and palpate the posterior and anterior fontanelle. And you want to note whether they are sunken or bulging, and what may have caused that. If it is sunken, it may be due to dehydration, or if it's bulging, it may be due to infection or increased intracranial pressure, or even crying. So now we're just going to note some skin on the baby's head. They may have something called a stork bite. Technical term is telangiectatic nevi, and this would be an irregular pink-shaped mark, and typically it's between the eyes and the top of the nose. And this is something that would blanch when you press on it, and this would resolve on its own. Or they may have something called port wine stain. Technical term is nevus flammis. And again, this is an irregular shaped mark on the skin. However, this is deep purple, dark red, and it would not blanch, and that's something that would not resolve on its own. So now we're going to talk about the types of swelling of the head, and there's two kinds. Caput succedaneum. This is edema between the periosteum and the scalp, and this does cross the suture lines. So this is more of a softer swelling. Or they may have something called cephalohematoma. This is a collection of blood between the skull and the periosteum, and this does not cross suture lines, and this is more of a firm swelling. So now we're going to move on to the eyes. They should be symmetrical. Their eyes may be swollen from the birthing process. We want to note the clarity of the eyes. The sclera should be white. However, they may have some red patches on the sclera, and that would be called a subconjunctival hemorrhage, and that would just be a ruptured vessel, and that's common from the birthing process, and that should resolve on its own. The infant's eyes shouldn't be discharging anything, and we want to remember that the lacrimal ducts are still immature, so their crying would be tearless. So now we're going to move on to the nose. This should be midline. We want to check the patencies of the nares, and we would do this with just one hand. We would lift the chin up, and that would close the mouth, and then we would press the side of the nose so that it occludes the nostril. And we want to just check the chest for rising and lowering during the breathing cycle, and we would do it bilaterally. We want to know if there's any cleft lip, if there's any nasal flaring, that would indicate respiratory distress. So now we're going to move on to the ears. The outer canthus of the eyes, if we draw an imaginary horizontal line, it should line up with the top of the pinna. Now if the ears are lower set, that indicates a genetic abnormality. We also want to do something called the cartilage recoil. That's where we would just bring the cartilage up forward, press against their cheek, and then release. It should just about immediately go back to its original position. However, it is common with preterms for their cartilage to stick. And we want to make sure that the infant is responding to sound, turning the direction where they hear noises. So now we are going to move on to the mouth, and here we would apply gloves. The tongue should be symmetrical, it should move freely, it should not protrude. We want to feel the gums, we want to check and note the presence or absence of teeth. We should feel the hard and soft palate. We also want to assess the suck reflex, and we do this by putting the finger in about halfway. The infant should suck. We also want to touch the back of their throat to elicit the gag reflex. We also want to do check the rooting reflex. We would stroke the infant's cheek and the infant would turn in that direction, thinking a food source was nearby. We also want to note for any circumoral cyanosis, that'd be blue lips, and that would be a sign of respiratory distress. So now you can remove your gloves. And we're going to move on to the chest. It should be shaped like a barrel, and the infant is a nose breather, however, they breathe using their diaphragm, and they shouldn't be experiencing any intercostal or substernal retractions. The clavicle should be intact, and you want to check this by palpating the clavicle and then putting the infant's arm through some range of motion. And you'll obviously be able to get more with the real infant. And something to note is if you start to move the infant's arm and they're screaming really loudly in pain, that may indicate that their arm is broken. The nipples should be symmetrical and well-formed, and we want to auscultate the heart rate always in the apical area, and that should be around 100 to 160 beats per minute. And the apical area is the left midclavicular intercostal space at the 4th to 5th space. Any murmurs that are heard are abnormal and should be reported. So now we're going to listen to the 5 heart locations. So we're going to start with the second right intercostal space, and that's where we'd hear the aortic valve. The left second intercostal space where we would hear the pulmonic valve. The left fourth intercostal space where we hear the tricuspid valve. The left fifth intercostal space where we hear the mitral valve. And then the left sixth intercostal space. We also want to check respiratory sounds, and we want to do this also in a set pattern. We should hear, the sound should be clear bilaterally. So we're going to start with the right upper, left lower, right lower, and middle. And if you hear any crackles or wheezing, this indicates fluid in the lungs. And report that to your nurse. And an absence of sound can indicate collapsed lung. So now we're going to move on to the arms. We want to take the brachial pulse bilaterally. So we'll reach around here. And now that we're touching the arms, this would be a good time to check the infant's ID band. We also want to elicit the grasp reflex, so we put our pinky in there. They should grab onto it. We want to know if there's any acrocyanosis. That's where the head and the trunk would be pink, but the hands and feet would be bluish. And this is common and present for several hours after birth. We also want to check the Moro reflex. So there's 2 ways we can do this. One is to make a loud noise and see the infant extend the arms and legs, and the fingers would curl, so you could just kind of smack the table. Or you could just slightly bring them up. The back of their head should still be touching and their shoulders. And then just kind of release, and that should startle the infant, and they should extend their arms, legs, and fingers should curl. So now we're going to move on to the abdomen. It should be round and non-distended. No shiny or taut skin. No lips of bowel visible through the skin. We want to auscultate the 4 quadrants of the abdomen, noting vowel sounds. Again, we want to do this in a set pattern. So we're going to start with the right lower, right upper, and left lower. Next, we want to palpate the liver. Alright, so now we're going to assess the cord. It should have 2 arteries and 1 vein. It should be clamped, it should be odorless, and exhibit no intestinal structures. And during the first few days of life, it could still be used for a pulse rate. So now we're going to move on to the genitalia. We have the female here. Her labia majora should be larger than her labia minora. Okay. The female infant may have some pinkish mucousy discharge, and that would be from the maternal hormones. If the infant's labia minora is larger than the labia majora, that would indicate a preterm infant. We want to also assess the anus to make sure it is intact. And the majora and minora and clitoris that may be swollen due to the birthing process. They should have a first stool after about 24 hours. So now we're going to move on real quick to the male infant. We want to check to see that his testes have descended, and we will do this by palpating. We're going to palpate the testes to make sure they descended, and it should feel like a marble. So do that. We want to make sure that the urethral meatus is at the penile tip, that it's not up or lower. We want to also note that the scrotum should have rugae, some fine lines that would indicate mature Newborn, we want to also check to make sure they have a patent anus, and if the male has been circumcised, we want to note that there isn't any bleeding or swelling or discharge. And again, that area may be swollen from the birthing process. So, turn that infant, switch it back. Alright, so now we're going to move on to the legs. We are going to lift up their thighs, and we're going to note symmetrical thigh folds. We're also going to check the femoral pulse, and we want to make sure that we do this bilaterally, however, not simultaneously, as that would elicit the vagus response. So we would feel that there. Over here. We would also check the Babinski reflex by starting at the heel and drawing a C upward to the toes, and the toes should fan out. We also want to check the plantar grip by placing the finger under the toes. The infant should grasp the finger. The newborn soles should be well lined. We also would note the ID band if it was present. So now we're going to turn the infant over. The spine should be vertical and midline. The spine should easily flex. And if there's any sacral dimple or hair tuft, that should be evaluated to rule out spinal bifida. And Mongolian spots are often seen in dark-skinned infants, most commonly seen over the sacral area. That's just something to note. And so we are now finished. So you can swaddle the infant, if that's allowed by your company policy, and hand it back to the mother or place it back in the crib.